Hello, and thank you for joining this Learning in Action Network and taking the time to watch and listen to this presentation on using a health equity lens to improve cardiovascular and minority health. My name is Tammy Geltmaker, and I'm with Adam Alliance, a quality innovation network with a 5-year, 5-state initiative to ignite powerful and sustainable change in healthcare quality. We welcome participants from Alabama, Indiana, Kentucky, Mississippi, and Tennessee, as well as other states that may be participating. We are honored to have Vivian Lasley-Dibbs as our speaker today. Vivian is the Acting Director and Epidemiologist at the Office of Health Equity for the Department for Public Health, as well as the State Coordinator for Healthy People 2020, and has over 20 years of public health experience. She holds leadership positions and professional affiliations that include national, regional, and state public health organizations, state and regional work groups, as well as civic and community-based organizations. Ms. Lasley-Dibbs earned a bachelor's degree in biology from Kentucky State University, a master's degree in hospital and molecular epidemiology from the School of Public Health at the University of Michigan, and is a graduate of the Physician Assistant Program in the University of Kentucky's College of Health Sciences. At this time, I would like to turn over the presentation to Ms. Vivian Lasley-Dibbs.
Thank you. I'm going to be speaking today about using a health equity lens to improve cardiovascular and minority health. I just want to go over a couple of objectives and make sure that we're all on the same page, and that's what I want to talk about today is defining a health equity framework, strategies to address cardiovascular health at the community level, and system changes that support and incorporate health equity as we work to address cardiovascular health. Just some working definitions, because in my work with health equity, people sometimes get confused with the definitions and the difference between health disparity and health equity. Health disparity is actually a health difference between an individual or a group or a population of people that's unfair because it's been caused by some social or economic disadvantage. As to where health equity is the opportunity for all people to attain their full health potential, and no one is disadvantaged from achieving that potential because of their social position or their class status or some other socially determined circumstance or construct. So when we think of determinants of population health, if you look at the pie chart, you can see on the right-hand side where we have all these other things that influence our health, our genes and our biology, which we can't control, health behaviors, medical care. On the left side of the pie is what we're going to be focusing on as those determinants of population health, those societal characteristics. And then there's also the physical and built environment, those physical determinants of health. So as we talk about our approach to healthcare and how social determinants of health came into play, historically we've been using the medical model or the downstream approach, where we focus on the disease and not so much the root cause of that disease. We've had a paradigm shift where we've gone back and looked at the socio-ecological model and really looked at what are the root causes that are impacting people's health. Is it those things that are where we live, work, play, and even pray? And what do those look like? So when we think of social determinants, we think of access to care, access to a quality education, sound economics, job opportunities, social support, our culture and social norms, how we interact with our communities, our language and literacy. All of those are social determinants. The physical determinants would be our built environment, where we live, our housing situation. Do we have bike lanes? Do we have walking paths? Are our roads in good condition? Are there physical barriers where we live that are keeping us from achieving optimal health? So in thinking about those things, we came up with the health equity framework. And that's really looking at how those social determinants really impact our health. If you'll notice from the slide, we have our health and well-being on the right-hand side, and then we have these intermediary determinants, which are these living conditions, our working conditions, our behaviors, and psychological factors. But then if you back up even further, there's things like social class and education and occupation that impact health. And then what sets the stage for those are societal policies, public policies, and social constructs that impact those even further. I love this slide because this was what Dr. Frieden, former director of CDC, put out for us to think about in addressing social determinants from a public health perspective. Traditionally, we've always worked at the top of the pyramid and worked with counseling and education and one-on-one in addressing a health disease or a health outcome that we're trying to intervene. We've shifted our thinking to think of where we would get the greatest impact would be at the bottom of the pyramid, looking at the socioeconomic factors, things such as poverty, education, housing, other inequalities that are impacting health. If we can address those, we can have the greatest bang for our buck, so to speak, in impacting long-term health outcomes. So how do we frame social determinants of health as it relates to cardiovascular disease and cardiovascular health? So there are some things I want us to remember as we start going down this path today, and that's a person's perception is a person's reality, whether that's real or not. And if there are problems in the community, then you've got to get the community involved so they can determine their own solutions. And we must appreciate that culture weighs each individual down while simultaneously providing a framework that holds that person up. So there's two things we have to think about with that individual. So how do we get started? So in a health equity approach, the first thing we have to do is you have to have an institutional commitment to do it. The community has to decide to address it, and so does the healthcare system. They're partners in this. When possible, align funding decisions with that commitment. There's got to be money to match the intent. Be deliberate in recruiting and building staff skills to advance health equity. Track and capture health equity efforts in training and performance plans. Integrate that into your services and resources that are provided by your entity. And establish multi-sector collaborations and relationships with diverse communities. We've got to come outside of our walls and really get to know the community in which we're trying to serve. I was ahead of myself. Get to know the community you serve. Find that community leader. Find that champion for you. Find that person that's respected, that people will listen to. And we've got to understand barriers that prevent community participation. Value community expertise and technical assistance. Work on building that relationship with the community and see what skill sets you have available in that community to achieve overall health and wellness for everyone. Community conversations are key. I can't stress that enough. Make sure that their voices are being heard. No one wants to think that they're saying things and no one's listening. Recognize that everyone in that community is not starting at the same place. You're going to have early adopters and you're going to have late adopters. And then, most importantly, you might have to reframe the message. You might have to start focusing on some solutions versus always pointing out the problem. So there are some tools that you can use to talk about health equity. Robert Wood Johnson has a very nice report on how to talk about health equity and other communication strategies to use in communities. That document really gives you a grassroots approach on how to talk about health equity to communities to where they buy into the concept, and it's a win-win for everyone. Engage external partners in addressing health equity. You don't have to do it alone. There are other folks in the community that are working toward health equity. Partner with them. Really understand social determinants of health and their impact on health outcomes. And then you want to really have a written work plan and a logic model that gives you a step-by-step roadmap on how you're going to apply the equity lens to every decision and evaluation that's made. And then ensure equitable access to the health care that you're providing. assumptions we always make sometimes is that, well, if we build it, they will come. Staff orientation and training is key. We need to be lifelong learners because communities change. We should be willing to change with those communities. And then I can't stress enough the importance of data. Being an epidemiologist, data is sometimes important. If we don't have the data in our world, we sometimes say if there's no data, the problem doesn't exist. But we have to know we have the data. We just got to find different ways of looking at that data and using it and leveraging it for a health equity and a health equity model. So what does all that mean? Well, I think we need to start shifting our focus. We really need to start addressing inequities, and we need to start looking through a social justice lens. We need to look beyond our interventions and our special programs and projects that we tailored and targeted to reach special populations. But we need to really focus on systems changes, policies, and changing systems to improve access to care, or environmental interventions to improve our built environment, as well as using a life course approach and starting from the earliest person all the way up to our most senior for our at-risk communities. So what are some examples of how we might do that? The use of community health workers is in marginalized and vulnerable and minority communities has proved invaluable. Lay health workers, community health workers, people that are known in the community, they are respected and they're valued, and people will come to them as a source for information and education. Health impact assessments. That's really looking at how something that's coming into a community, whether it be a new business, a new industry, a new park, a new school, how that's going to really impact a certain community. Is it going to be useful to that community, or is it going to be more of a hindrance to that community because of some of the effects that that's going to cause in that community? Health and all policies is really looking at other agencies, transportation, housing, education, and how the policies that they have are impacting health. Those they may not know about and those that they are thinking about in the future, that they need to look through a health equity lens in developing new policies. And then the last one that's really important is to build resilience within communities, at the individual level and then at the community level. And all of that is going to impact the health resilience of that community. People need to feel empowered. They need to have the basic skills that they need to be successful in life and feel empowered that they can really impact their health. And then that becomes contagious, and then the community becomes sustainable. And then that, in turn, creates a positive health outcome for that community. So what is community resilience? Let's talk about that a little further in developing that. It's a community's ability to prevent, withstand, and mitigate the stress of a health incident. And that community's resilience is how they recover, how they restore that community to a state of self-sufficiency, how they continue to function and have those social networks after a trauma or a health incident. And most of the time, that community resilience is relying on a past event, how they strengthened themselves before to withstand something prior. So they're building on that past knowledge in order to build that community resilience. And I think that's important because once that community has done that, once they have that social connectedness, once they have that frame of reference, then they can meet their whatever health obstacle or health entity that's impacting their community to build that health resilience. And all of this is meeting communities where they are. Let's think about the community approach. How do we get into communities and work with communities to empower them, to make them feel that they can be in charge of their own health? One of those is to work with a faith-based community. And I'd like to share one of the projects that's had success through the Million Hearts Initiative, which is Bless Your Heart. And that's a faith-based initiative within the African-American community that's using the church and the health and wellness ministries within those churches to really address cardiovascular health from a spiritual standpoint, a biological standpoint, and from a healthcare access standpoint. And has really been successful in engaging the community to take charge of their own health. Along with that is the Care Collaborative, which is looking at the ABCs of health, which is the hemoglobin A1C, the blood pressure, and I want to say obesity and weight as it relates to cardiovascular disease. And all of these are community-led initiatives and must not negate neighborhood associations taking up walking clubs and improving their parks within their communities to take charge of their own health. And then the central components of all of these are intense training on both parts, building community capacity and sustainability, increasing human capital, and guaranteeing that there's going to be treatment available if things are found that arise out of these initiatives, that they can be addressed. So how do you go about doing that? Well, you have to build a community-wide, continuous learning environment to really address cultural issues, social determinants of health, and whether it be cancer screening, cardiovascular screening, and equip that community to build and manage and leverage their own patient-provider relationships. Identify where your gaps are and fill them. If it's access, if it's resources, if it's data, if it's whatever those gaps are, come up with a plan to fill those. Develop sustainable skill sets. Leave the community with something that they can use. Many times we go into communities and point out deficiencies and point out where they are going wrong, but we don't leave them with anything, with a skill set or anything that they can use to improve their situation. Equalize the individual, community, and health system, from the community to the healthcare system, and from the healthcare system back to the community. There's a nice balance and exchange there that has to be reached. So what can you do? You can build self-awareness. Know your own prejudices and think about your own attitudes and those unconscious and implicit biases that you might be bringing to the table. The lens that you look through is not necessarily the lens that the patient or the community is looking through. Distinguish the perspectives and consider those various points of view. Be an active listener. You can learn a lot from what's being said and not what you want to hear, and it may not be what you want to hear. And you can also learn a lot from what's not being said. Being open to learning about other cultures and acquire more training on health equity and cultural competency. Really get your head around what those definitions are and what cultural competency means to you and to your organization. And then you're going to ask yourself, now that we know all this, are we poised for progress? Do we have a collaboration among our diverse stakeholders? Have we done community engagement? Have we prioritized based on what that community has told us their needs are? Are we using evidence-informed strategies? Are we focusing on policy systems and environmental changes? And are we evaluating and sharing our results? Give the community the feedback. Let them know that you're listening and that you have implemented these things to make them feel like you really care about their health and health outcomes. So in summary, think big picture. Think about those social determinants of health. Think about using the health equity lens and addressing cardiovascular disease and other disease entities. Think about what that might look like in communities and how you can be flexible and adaptable to those communities. And remember that the community's perception is their reality. Thank you very much. It's been a pleasure. Some references for you and my contact information.
Thank you very much, Vivian. And to everyone who has joined us today, Adam Alliance is here to help you. Please contact us if you have any questions about what you just heard. We will email you an evaluation of this event and sincerely appreciate any feedback you can provide so that we can continue to offer opportunities that interest you. There are many resources available on our website, www.adamalliance.org. And finally, we are out there on social media. here are just a few ways to connect with us. Thanks again, and have a great day.